the information we've reviewed. During a blood pressure screening, a client was told that her blood pressure was a little bit high. She was advised to see her primary care physician. J.E. is 42 years old, married, and the mother of 2-year-old triplets. She is 5 feet 6 inches tall and weighs 210 pounds. She says her father had hypertension and died of a stroke. At the ambulatory care clinic, you take her blood pressure. It is 156/92. She asks you if you think she really needs to be evaluated for high blood pressure. She says she feels just fine. What should you tell her? You should tell her that untreated hypertension damages the heart, kidneys, eyes, and brain. Most people, just like her, have no symptoms. What risk factors does she have for hypertension? Obesity, a high-stress living situation, and a family history. We are assuming, of course, that being the mother of 2-year-old triplets can be stressful. So the physician sees the client and recommends following a weight loss program and monitoring her blood pressure weekly. What other lifestyle modifications might help lower her blood pressure? Limiting her salt and fat intake, stress management, relaxation techniques, and exercise. After 3 months, J.E. has lost 15 pounds, but her blood pressure still averages 152/86. The physician recommends drug therapy, starting with hydrochlorothiazide. What is hydrochlorothiazide, and how does it work? It is a diuretic that works by lowering blood volume and decreasing the sensitivity of blood vessels to sympathetic stimulation. What are some of the adverse effects of hydrochlorothiazide? Hypokalemia, blood dyscrasia, and orthostatic hypotension. Let's approach our next review as though you were a newly employed nurse attending your facility's critical care course in preparation for working in the CCU. We've just come to the part of the presentation that covers congestive heart failure, or CHF. CHF is the heart's inability to pump effectively, thus compromising the distribution of oxygen to the body's tissues. CHF often appears in discussions of myocardial infarction, leading to pulmonary edema, coronary artery disease, and hypertension. Today, we'll elaborate on the nature of CHF, its treatment, and most importantly, its nursing management. The body attempts to compensate for heart failure by several mechanisms. The sympathetic nervous system responds by releasing epinephrine and norepinephrine. These catecholamines stimulate the heart rate and force of contraction and constrict peripheral blood vessels. Decreased renal perfusion triggers the renin-angiotensin-aldosterone system. Angiotensin II, a potent vasoconstrictor, raises blood pressure by increasing peripheral resistance and stimulates secretion of aldosterone. Aldosterone makes the kidneys retain sodium, which in turn causes water retention, and over time, the left ventricle hypertrophies in an effort to overcome increasing peripheral resistance and fluid volume. As you know, when compensatory mechanisms can no longer maintain homeostasis, the client experiences the effects of inadequate circulation. The sequence of events is as follows. First, myocardial contractility, stroke volume, and cardiac output decrease. The left ventricle cannot handle the incoming blood volume, so blood backs up into the left atrium. Pressure in the left atrium causes blood flow in the lungs to become congested. The leakage of fluid into the lungs is called pulmonary edema. Pressure in the pulmonary vessels increases resistance to the influx of blood from the right ventricle. Resistance to the influx of blood into the right ventricle increases pressure in the right atrium and eventually in the venous system, causing peripheral edema and enlargement of the liver and spleen. Note that this process can originate in either the right or the left side of the heart. When the basic problem is high peripheral resistance caused by atherosclerosis, the left ventricle will fail first because it must pump against abnormally high resistance. Clients who have pulmonary disease may develop right heart failure first because of resistance to the flow of blood into the lungs. Eventually, both sides are usually affected. If not treated effectively, the blood flow to the myocardium diminishes and compensatory mechanisms fail. The client is at risk for dysrhythmias, renal failure, ventricular aneurysms, and death. Any factor that places excessive or prolonged strain on the heart can lead to congestive heart failure. What are some examples that you can think of, and which clients would you assess for CHF? Cardiovascular disease, including atherosclerosis, complicated acute myocardial infarction, cardiomyopathy, hypertension, congenital defects, and defective heart valves. Inflammatory or degenerative muscle disease, advanced age, alcohol abuse, hypoxia, COPD, and pulmonary hypertension. Other examples are clients who have anemia, fever, or excess fluid volume. How about clients on cardiotoxic drugs and other drugs that suppress myocardial contractility or electrical activity? The primary way to prevent congestive heart failure is to treat risk factors promptly. In the CCU, you'll have clients who have the signs and symptoms of left-sided heart failure. What will you assess them for? Tachycardia, dysrhythmias, and an S3 heart sound, dyspnea, cough, crackles, and wheezes over lung fields, orthopnea, frothy sputum, anxiety, confusion, and falling blood pressure. Remember that left-sided failure causes pressure to back up, forcing fluid to seep from capillaries into the lungs, so the client would have significant pulmonary symptoms. Other clients will have signs of right-sided failure. What will you look for with these clients? Increased CVP, jugular distension, peripheral edema, and weight gain. They'll have liver enlargement and tenderness, ascites, fatigue, weakness, and nocturia. The thing to remember with right-sided failure is that pressure is rising in the venous system, so you will see more edema in the dependent tissues. Remember that clients will often have both right and left failure, with manifestations of both. A diagnosis of congestive heart failure is usually made based on the client's history and physical. Various diagnostic tests and procedures are done to assess causative factors and complications. What would you expect those tests or procedures to be? ECG, chest X-ray, and ultrasound, specifically an echocardiogram, serum electrolytes and hematocrit, and lipids. You might check lab values for atrial natriuretic factor. The amount of elevation is proportional to the degree of heart failure. Other tests include arterial blood gases, cardiac enzymes, pulmonary function test, and measures of liver and renal function. When treating a client with CHF in CCU or in any clinical setting, medical management focuses on correcting the underlying cause, improving cardiac function, eliminating excess fluid, and decreasing the cardiac workload. What are the interventions for the underlying cause? Valve replacement and treatment of dysrhythmias. When we talk about drug therapy for CHF, we'll discuss multiple drugs. Are you familiar with the various drug therapies? Cardiotonic inotropics are given to increase myocardial contractility. Digoxin has traditionally been the inotropic of choice. However, the first approach now is more likely to be a combination of ACE inhibitors, diuretics, and beta blockers. Diuretics are given to eliminate excess fluid. Spironolactone has been associated with increased survival with CHF. Vasodilators like ACE inhibitors and nitrates might also be prescribed to reduce preload and afterload. Morphine to reduce myocardial oxygen consumption, decrease anxiety, and dilate blood vessels. Remember to watch for respiratory depression if your client has been given morphine. And finally, oxygen therapy is prescribed to increase the concentration of oxygen in the blood. Other interventions just seem logical when you consider the disease process. How about sodium restriction to 2 grams per day to help reduce fluid retention? Fluids might also be restricted. Devices used to decrease cardiac workload and improve oxygenation are the intra-aortic balloon pump and mechanical ventilation to improve oxygenation and perfusion.